Thank you, everyone. We'll get started now. So my name is Rebecca Armstrong. I'm the Director of Patient Education and Engagement with the Canadian Breast Cancer Network. Before we get started, I'd like to cover a few housekeeping items. So the session is being recorded and will be available on our website for anyone who may have missed it and wants to rewatch it. I'll send out a link once the recording is available. And in the meantime, you can find our previously recorded webinars on our website as well. I'd also like to extend our sincere appreciation to our sponsors for today's events, our gold sponsor, Pfizer, and our bronze sponsors, Bayer, Tracera, AstraZeneca, and Eli Lilly. Our questions and expert sessions are strictly dedicated to answering your questions, so there will be no presentation from our speaker, and he'll be answering live questions from participants along with ones that have been submitted in advance. You can use the Q&A button at the bottom or side of your screen to submit your questions, and we'll aim to take as many as possible. Our speaker today will do his best to answer your questions, but please note that he may not be able to speak specifically to individual situations without having a complete medical history. I'd now like to welcome our host for this session, Kathy Amendolia, who is the chair of the board for the Canadian Breast Cancer Network and has the lived experience of being diagnosed with breast cancer herself.
Thank you, Rebecca, and welcome again to everyone. Thank you for joining us. I'm pleased to welcome Dr. Omar Khan, who will be joining us to answer your questions about HR2 breast cancer. Dr. Khan is a clinical assistant professor at the Cummings School of Medicine and medical oncologist at the Arthur J. E. Child Comprehensive Cancer Center. His current clinical practice includes the breast cancer and sarcoma tumor groups. His research interests are in the application of artificial intelligence to clinical cancer care, including projects focusing on imaging biomarkers to predict prognosis in several tumor types, including lung, prostate, breast, colorectal, and hepatocellular carcinomas. Sorry about that pronunciation. When you live in the breast cancer world, it's kind of hard. Thank you, Dr. Khan, for being here with us today. And also, we're joined by Jacqueline Carter, who brings her perspective as a patient advocate and CBCN patient ambassador. Jacqueline, we're so happy to have you here. And to start off, we'd like you to take a moment and introduce yourself.
Thank you so much, Kathy. So my name is Jacqueline Carter. I am a breast cancer survivor. I was diagnosed at the age of 33, just a little over 4 years ago, with estrogen and progesterone positive stage 2B breast cancer. I got involved with the CBCN just out of a desire to kind of give back to the community that supported me through the most challenging period of my life. And specifically because of the age I was when I was diagnosed, fertility was top of mind for me. I had not yet had children. And that was something that I wanted to share with others who were in similar boats, who had been diagnosed, but hadn't yet had children. And that was something that they really wanted. So I joined to be an advocate for hormone receptor positive breast cancer here at CBCN, but also to support those who are passionate about their families. And I'm happy to report that I have a healthy baby at home. She's going to be 1 in July. And that was all thanks to the support of my own medical oncologist who's in the room with us today, Dr. Omar Khan. So very happy to be here and to be having this conversation with you all.
That's a great story. And that's why we're all doing this work. Thank you for that introduction. And I'm going to ask you, Dr. Khan, to tell us a little bit about yourself, your work, and your research.
Sure, thank you very much. And I'll start with an apology because I probably should have said liver cancer instead of hepatocellular. So I kind of tripped you up there from the very beginning, and I'm sorry about that. So I'm a medical oncologist in Calgary. I'm actually a bit of a lifer. So I was born in Calgary and I did all my training in Calgary as well. So I have a Flames jersey up there behind me. And as I mentioned, I treat breast cancer as well as a rare type of tumor called sarcoma, which is bone and muscle tumors. So a lot of my work is the clinical practice. And so I spend about 3 days a week in clinic. And then I do a bit of research as well. So I've got a few different research projects that I'm working on, primarily looking at how we can use imaging to try and predict outcomes, but also decide, can we identify patients who need certain treatments or maybe don't need as many treatments using some of the imaging data that maybe we're not actually fully leveraging at this point in time. Um, and then I'm also doing some work with Breast Cancer Canada. I'm on their scientific advisory board, and we have a few projects on the go. So one of them is looking at patient-reported outcomes. So there's a tool called Progress Tracker, um, and where patients who are living through breast cancer at any stage are able to kind of report in their own lived experience, so we can better understand across Canada how patients are being treated, what symptoms they're having, and how we can better care for them. As well as in Alberta, we're working on in the metastatic or stage 4 breast cancer space, trying to better understand this population of patients and how we can again treat them better. So I've got a few different hats that I'm wearing now.
That's great. Thank you for all the work you do. Patients really
My
appreciate it.
pleasure.
Yeah. So before we start, I just wanted to ask you quickly, just a little bit of an overview. I know we're going to touch on a lot of things throughout this hour and a half. In terms of like Jacqueline was saying, young women being diagnosed with HR positive and, you know, fertility and all that. In the time that you've, you know, had worked in your career, have things changed a lot in terms of support and knowledge by patients when they're diagnosed?
Absolutely. I think, and trying not to age myself a little bit, but I don't think I've been an oncologist for that long. And in all aspects of cancer care, I think there's huge changes that are happening. So it starts from the beginning in terms of, there's evolutions in our screening approaches to diagnose breast cancer. There's evolutions in how we actually diagnose them and what things on pathology we're looking at and how we understand these receptors that breast cancers have. Um, the types of treatments that we're offering and the sequencing in which we do these treatments is changing dramatically even over the last 5 years. And from a patient support perspective, I think our systems are getting a lot better at actually understanding, honestly, thanks to advocacy from patients and families, that we need to think a lot about some of the other aspects that goes through a human going through cancer as opposed to just the cancer itself. And that is things like fertility, that's things like psychosocial support, that's things like survivorship care after the treatment, that's things like trying to manage and prevent side effects as well as treat them. And so in all of those areas, I think that there's been a lot of evolution. And it's part of what makes, honestly, working in oncology exciting, is that there is so much change happening. It also makes it a little bit challenging to keep up with, but it's very, very worthwhile.
Thank you. And for treating patients, what is the difference in the way patients are being treated today with HR positive, let's pick early stage, young women, versus what we used to do, or the medical community used to do, oncologists used to do, is like stage a person and then, offer them what was available. What is the difference? And with that question, I also would like to ask, is there, the focus of less treatment with HR positive patients than there used to be?
So it's a complicated question because I think the first part of it really comes down to, can we do a better job of actually understanding what the risk associated with a cancer is? Um, and so when I think of risks associated with cancer, the primary thing I'm worried about is the risk of a cancer showing up somewhere else in the body, but also the risk that it causes more symptoms locally in the breast or the lymph nodes. Um, and if we can better understand that risk, and so some of our more recent evolution in testing is, things such as, for example, oncotype testing, to see who actually needs chemotherapy or not after they've had surgery for breast cancer. And that's just one example. There's several models that are happening now to try and better understand the risk associated with a cancer. And a person who has a lower risk cancer, it doesn't make sense to put them through as many side effects, trying to reduce that risk more potentially. Whereas somebody who has a higher risk cancer, it probably makes sense to say, hey, we need to be more aggressive with treatment. And so across the board, are we reducing the amount of treatment we're giving patients? I think that's probably not true. There are some patients in whom we're talking about more treatments and newer treatments, ways that we can actually target the biology of the cancer in different ways. But then there's other patients in whom we're actually saying, hold on, we don't need to give all of these side effects to everybody. But it really comes down to that individual, more personalized assessment of risk than we were previously doing. Staging is a good starting point, but there's so much more that we understand about the biology of cancers now, including their grade, their receptor status, these tests like Oncotype that look at different gene signatures within the tumor to figure out what's causing it to grow. So there's a lot happening there for sure.
Thank you. So I will now start with a question that was submitted in advance. So I'll begin with this question is how is bone metastases detected in patients with early stage ER positive breast cancer?
So yeah, it's a really good question. I think the first thing really is, are you having symptoms that would make us concerned about it? So to me, that's always the first question whenever I'm meeting a patient who has a new diagnosis of breast cancer. That's one of the things I'm trying to go through. If somebody is not having any symptoms that worry me about the bones, then the next step is exactly what I was just talking about, which is how do we identify what the risk of cancer having moved to the bones in that person is. So for example, if you have a really small tumor in the breast that doesn't involve the lymph nodes and it's a low grade, the chance of it spreading is so low that the risks from the testing might actually outweigh the chance of finding something. That's things like radiation from CT scans. And truthfully, even like the anxiety that goes with kind of getting these scans and not knowing what the result is or what it means. And so we have guidelines, for example, Cancer Care Ontario has guidelines on who we need to do staging investigations on. Alberta has guidelines and other provinces have similar guidelines as well. And actually Canada's been fairly ahead of the curve on this because even international organizations like the American Society of Clinical Oncology have actually endorsed some of the Canadian guidelines on who to do staging in. This type of testing might include in specific cases things like CT scans, bone scans to look at the bones. In some cases, we might do another type of test called a PET scan, which looks at metabolic activity. And generally, we use this type of testing for patients with stage 3 breast cancer, although there are some stage 2 patients who we may also do this type of testing in.
Okay, thank you. And how do you distinguish between benign causes like joint or muscle strain and more serious metastatic pain?
Yeah, the characteristics of the pain itself are really, really important here. And I think working with your healthcare team to kind of identify these different characteristics is really, really important. One of the big questions is, I kind of half joke with my patients that like, did you do something to deserve the pain? So if you've been like, moving and you've been lifting and all that kind of stuff and your muscles and joints hurt for a few days, that's totally normal. As a cancer patient, you're still allowed to get everything that every other human gets. Jacqueline's laughing because she's heard me say this before. But that's really important to me is, is there a specific cause that I can identify? Does the pain get better with activity or worse with activity? That's an important characteristic for me as well. Things that get better with activity are less likely to be cancer related and potentially more likely to be treatment related. And then how does the pain pattern change over time? So is it getting progressively worse where it's like, it was mild, but now it's just getting worse and worse and worse? Does it wake you up from sleep? Because that's pretty unusual for pain to do. Those are the other kind of red flags that I'm watching for to help me distinguish between those things.
And I would imagine that the first few years, I don't know where you have your years early on, is a time where you have a little more vigilance in terms of assessing these pains or different things that are happening to the patients physically, correct?
Right. Yeah, absolutely.
Yeah. Okay. Thank you. So, Jacqueline, let's take a couple of questions from you.
Thanks, Kathy. Okay, so I just want to jump back to the fertility thing. So just wondering if you can talk a little bit about fertility for young breast cancer patients, I guess specifically in the hormone receptor positive space, but probably generally as well. What specifically do those newly diagnosed who hope to have families in the future need to know now to best advocate for themselves and their future families?
I think the first and probably most important thing is to actually talk with your healthcare team about it. As healthcare providers and systems, I do feel like we're getting better at also approaching patients about this. Like in our electronic medical record in Alberta now, there's actually like a pop-up that shows up, which is like, oh, this is a patient who is likely, eligible for oncofertility care? Have you talked to the patient about this? And so there's things that we do as a system, but at the same time, this is a great place where a patient can advocate for themselves. And it's one of those things that if we know that it's important to you, then there's lots of things that we can do to try and help facilitate that. There's a lot of our cancer treatments can actually affect fertility, whether it's things like chemotherapy, which can have a potentially permanent effect on fertility. Estrogen blocking medications that we use for hormone receptor positive breast cancers can also affect fertility. And often those medications are actually what we call contraindicated, meaning we can't use them in pregnancy. And so this is important both while you're receiving the medications, but even before you receive the medications. And so, getting connected if you're interested in fertility and discussing fertility options with a fertility specialist before you start your cancer treatment is actually a really important thing. And that's why it's so important to really bring it up, honestly, at that first appointment to say, hey, this is something that's really important to me. Because we have several options. For example, when we're giving chemotherapy, oftentimes we will do something like egg harvesting or banking before chemotherapy starts so that we know that chemotherapy hasn't had any effect on the ovaries at that point in time. We can also sometimes give injections to make the ovaries sort of sleep through chemotherapy so that they're less likely to be affected. So there's different options that we can discuss, but we can't discuss those options if we haven't realized that this is an important thing to talk about.
Can I ask a quick question around that? It's concerning endocrine therapy. So chemically, you would put a young person into menopause, right?
Correct.
So how do you manage that for fertility?
Well, so I think there's different pieces to that. And I think that kind of really speaks to how hormone receptor positive breast cancer is a bit different. There, there's two issues with that. Number one is that, like I said, pregnancy, you can't have pregnancy and be on a medication like tamoxifen at the same time because these medications, same with chemotherapy, if you get pregnant while you're on chemotherapy, there's a very significant risk to the fetus. But the issue with hormone blocking therapies in particular is that they're given for a long time. Right? We're talking 5, maybe even 10 years in some cases. And so planning for fertility is really important. There was a big kind of global clinical trial that I used to guide me when we're helping hormone receptor positive patients through decisions about fertility and pregnancy. It was called Positive. And what it did was they followed patients wishing to have pregnancy after about 18 months of estrogen blocking treatment. Patients were able to come off of the treatment. They had up to 2 years to conceive and then restarted the estrogen targeting treatment after pregnancy and breastfeeding. And what this study thankfully showed us is that there was not a higher risk of cancer recurrence when this approach was taken. Now, in every situation, again, it's really important to speak again with your medical team because they have a better understanding of specific nuances and things that we need to consider in your specific case. But this study really gave us kind of an evidence-based leg to stand on to say this is how we should approach fertility and pregnancy in this important group of patients.
I think Kathy might be frozen.
Yeah.
I can just jump into my next question if that's okay, Rebecca. So I guess just more broadly, maybe you can talk about some of the distinctions between like what sets hormone receptor positive breast cancers apart from other types of breast cancer, and what should those patients diagnosed with hormone receptor positive cancer keep in mind?
Yeah, so I think what is the length of time that the treatment happens over? And I think that's important in 2 ways. One is that there's likely new research coming out while you're still on your treatment. Whereas if I'm giving you like a treatment that's only like 3 or 6 months long, like chemo, the likelihood that something drastic has changed during those 3 to 6 months is a lot lower than if something drastically changing over 5 to 10 years of being on estrogen treatment. And so I feel like as a hormone receptor positive breast cancer patient, especially in the early stage setting, it's important to kind of keep your finger on the pulse, so to speak, of like, what are the new developments happening? Are there new tests? Are there new treatments that are coming out that we might think of? It's also becoming more and more complex. So there's a lot more treatment options. So before it used to be basically we had like, originally one medication, tamoxifen, that everybody got. And then the aromatase inhibitors came out, and that was another option we could use in postmenopausal patients. Then we started to use injections to put the ovaries to sleep and essentially induce menopause. And then now we have additional medications that maybe target some of the ways that cancers can start to work around the treatments that we would normally do. And so for higher risk breast cancer patients, we're often using additional medications now, like abemaciclib or ribociclib. These are what we call the CDK4/6 inhibitors, and that's a pathway that's downstream of the estrogen receptor. So even if our estrogen treatments are not working, if we block the next step down the chain, so to speak, or the escape route the cancer can use, that might be helpful. And so there's a lot of things that are changing. And don't be surprised if your oncologist is kind of dropping things on you. It's like, oh, and we need to talk about another thing. I think that's probably one of the things that I find challenging as an oncologist, especially in the hormone receptor positive group, is when I first meet somebody, there's so many things we have to talk about, and it's a very overwhelming visit. And so I try and give kind of that bird's eye view. But the reality is that a year later, when I'm talking about something, it's probably different than what I had originally talked to them about, because something new has come up, or there's a new treatment like ribociclib just got Health Canada approval on June 19th, this year. And so now I'm starting to talk to patients about it because we didn't have Health Canada approval for that medication. And so don't be surprised if your oncologist periodically kind of drops something on you that's a bit of a surprise in terms of a treatment. That's just kind of a nature of oncology right now.
Sorry,
Thank
I'm
you.
back.
Welcome back, Kathy.
It's computer's situation. Okay, so sorry I missed Jacqueline's question and your answers. So we're gonna ask Rebecca to ask 2 or 3 live questions. Go ahead, Rebecca.
Thank you. So the first question we have coming in is, how much of an influence does PR negative marker have on prognosis?
That's a really good question. So we think of estrogen and progesterone as both being quite related. Generally speaking, when a tumor is both estrogen and progesterone receptor positive, it tends to respond better to the estrogen targeting treatments. We don't have any specific progesterone targeting treatments that we use because the pathway is actually very similar. And so our estrogen targeting treatments kind of try and hit that same pathway. PR negativity is only one of several factors, though. So again, you have to put it in the context of everything else with the tumor, and that's part of what makes personalized medicine more difficult. Is we can't just look at one thing and say, oh, this is what matters the most. It's how you combine all of the different risk factors and all of the different characteristics of the tumor together. So for example, if you have a 1 centimeter ER positive, PR negative tumor that had no lymph nodes involved and was a grade 1, that's still going to be lower risk than a tumor that's ER and PR positive but had multiple lymph nodes involved. And so all these factors have to be contributed. So is it an important factor? Yes, we definitely consider it, but it's certainly not the only one.
Great, thank you. So the next question is, I've recently read that although HR positive breast cancers generally have a better prognosis, those with BRCA2 mutations who are ER positive have a worse prognosis than those who are ER negative. I wonder why this is different for people without a mutation.
So I think a lot of that actually goes back to, first of all, ER positive breast cancer is less common in BRCA mutated patients, so triple negative breast cancers are a lot more common. And what that means when something is less common is that the kind of the variance around the statistics is quite a bit wider, or the confidence interval, as we call it. And so I don't know that I'm quite convinced yet that hormone receptor positive breast cancers in BRCA mutation patients actually have a worse prognosis. I think we still need more studies to answer that question. But the second thing, again, is that it's one of many factors that are really important. So the stage of the breast cancer actually really matters as well. And there's a lot of other risk factors that I think combine into that. And then also the length of time that you follow patients up for is really, really important. So if you do a study with a short-term follow-up with breast cancer, we really need longer durations of follow-up. And truthfully, we haven't been as commonly testing for mutations like BRCA until like relatively recently, like the last 10 years, where we've really started to ramp it up. And so I think there's a lot more data that's going to come on this. So I'm not quite ready to kind of attribute that just yet.
Thank you. And then one last question before I give it back to Kathy. So what is the best way to test if two primary cancers are related? Specifically, this person is thyroid and breast.
Gotcha. So um, it depends on the specific cancers as well. So there are some cancers, we were just talking about BRCA mutations. There's certain mutations that um, predispose to certain cancers. So for example, the BRCA mutations predispose to breast and ovarian cancers, along with some others like prostate, pancreatic cancer, melanoma potentially. Um, One of the best ways is to actually have a really good understanding of what your family history is. So who in your family had cancers, what type of cancer, what age, and really knowing where that cancer started. So for example, like if you have a breast cancer that moves to the bone, that's not a bone cancer, that's a breast cancer in the bone. I often give the example of like if I go to Australia, I'm not an Australian, I'm a Canadian in Australia. And it's really important for us to know if this is like a breast cancer that's in the bone. Um, and so knowing your family history is really important. Talking to your care team about your family history is also really important because that helps us identify trends. And then if there does appear to be a pattern that might be more consistent with one of these hereditary mutations, then we would do additional testing. And so each province has criteria that they use to determine which patients would be eligible for provincially funded testing for these hereditary mutations. In Alberta, if you don't meet those criteria, the risk of having a hereditary mutation is somewhere around 5%. And so there's still some patients who don't meet criteria who might have a mutation, but that risk is relatively low. You do have the option of getting testing privately if you don't meet the criteria as well. It's usually a few $100s to get that testing. But there's a lot of important things to think about because if you do have a mutation such as BRCA, there might be additional procedures that we consider for prevention of other cancers. It might have an impact on your other family members. And so again, this is something where it's really important to talk with your care team to really talk about the kind of the pros and cons of testing in your specific scenario so that you can make an informed choice about whether you want to do that or not.
Thank you. Back to you, Kathy.
Yeah, so just quickly around that, I guess family history and populations come into factor when you do testing for BRCA, correct?
Correct. Yeah, absolutely.
Okay, because we know certain populations, if you'd like to go into that so that the audience can get a little bit of a refresh, because I
Yeah.
live in Quebec and I know the French population, French Canadian population gets tested, and we have a large Jewish Ashkenazi community here, so those populations ultimately get tested.
Yeah,
So if you
absolutely.
could go into details about that, that would be
Yeah,
great.
so there's and the testing criteria do vary a little bit by province. So that's why I haven't been too specific thus far, but I think there's some general principles that I can talk about. You're absolutely right. There's specific populations like the Ashkenazi Jewish population where they are eligible for testing. If somebody in your family has had a known mutation, then you're eligible for testing as well, of course. And then it really comes down to the type of cancer and the age at which it was diagnosed. And so having breast cancer at a younger age is much more likely to be associated with a hereditary mutation potentially. Um, Having ovarian cancer at any age is more likely to be associated with a hereditary mutation. And so if you have a family history of ovarian cancer, that would make you eligible for testing. Um, and then the number of relatives who have had a cancer. So for example, if like everybody in your family has had breast cancer, and especially if someone who is male in your family who has had breast cancer, because breast cancer is much more rare in males than females, those would all be reasons that we might do testing. The actual genes that we test are changing over time as well. So, and you know, not everybody knows their family history as well. So there are certain criteria that we use to say, hey, you need to get testing. Other criteria might be based on, again, your diagnosis. So if you're 25 and get diagnosed with breast cancer, we're not as worried about your family history. You need testing anyway. Um, so there's patient and family factors.
Thank you. So I'm going to go back to the submitted questions. How common and how serious is endometrial intraepithelial neoplasia in EIN in postmenopausal women who have taken tamoxifen for a few years, followed by letrozole?
Yes, this is a really good question. And really what it's speaking to is some of the uterine side effects that can happen from tamoxifen. So I think the first thing that's really important to note is that it is specifically tamoxifen that can cause these side effects. So medications like letrozole, the aromatase inhibitors, are not associated with uterine side effects like this. Um, these side effects from tamoxifen are also quite rare, thankfully. So there was a study out of Korea published a few years ago that like followed, I think it was like 70,000 patients, out of which about half had tamoxifen and half had not, to kind of get a sense of like how commonly were some of these uterine side effects happening, specifically in premenopausal women. And what they found was that the risk of having a polyp in the uterus, which would generally, sometimes it can cause bleeding, but generally would be fairly benign and not likely to become cancerous, that was about 20 cases per 1,000 patient years. So, but say a person year, what that means is, for example, like, every year of life for a specific person. The risk of getting endometrial hyperplasia, which is where cells are starting to maybe become a bit abnormal and are starting to become higher risk for developing a uterine cancer, that was about 13, so 1.3 cases per 1,000 person years. And the actual rate of endometrial cancer, which is the thing we worry about the most, was about 2 cases per 1,000 patient years. I think a few things that are important about that is the risk of the uterine side effects does gradually increase over time as you've been on tamoxifen for longer and longer. And so if you're on tamoxifen for like 2 years and then switch, that's different than if you're on tamoxifen for say, pardon me, say 10 years or 15 years. And so the duration of exposure to tamoxifen is really important. The risk is a bit higher in postmenopausal women compared to premenopausal women, largely because you're shedding the uterine lining when you have a period. Although, of course, if we're giving medications to render a premenopausal patient postmenopausal, then we still need to be vigilant for this. And then typically, bleeding is our first symptom, and it tends to happen before a cancer develops. And so I think the most important thing for somebody who's on tamoxifen is, I always say, if you're getting vaginal spotting or bleeding, I need to know. And so it's really important that you talk to your care team about that, because we can do things like ultrasounds or referral to gynecology to make sure that it doesn't develop into something more serious. So we do take the side effect quite seriously, but at the same time, everything we do is kind of risks and benefits, and it's always important to kind of weigh those things out in terms of how much does a medication like tamoxifen reduce the risk of your cancer coming back, and how do we weigh that against some of these side effects.
And so what is the management? This is my own question around your answer. What is the management for a woman when they're, on these drugs? Is an annual gynecological exam fine so that the gynecologist can assess the uterus, or if they find
You
they
don't
have...
necessarily need to have like a set frequency for examinations. The guidelines really tell us that it's symptom based. So you don't need to do like
Okay,
ultrasounds every year. Again, that's a fairly invasive test and exam to be doing now. Again, as part of like regular screening, for example, for cervical cancer and things like that, you should still be getting those things.
right.
Um, and certainly, again, the big thing for me is if you're getting spotting or bleeding, that's really, really important.
And how long after you've finished your 5 and 5? I go 5 years to tamoxifen. I'm always thinking of that. 5 years tamoxifen, 5 years letrozole. How far out can you say, well, I don't have to worry about this being a problem, having caused a problem for my uterus?
So if you stop, like for endometrial polyps and endometrial hyperplasia, even kind of overgrowth of the lining of the uterus, if you stop tamoxifen, that'll actually reverse on its own. And so I
Okay.
wouldn't be worried about it once you stop tamoxifen. Again, everybody's, depending on your specific case, you might be on tamoxifen for a different duration of time. So a lot of people are on it for like 2 to 3 years. Some patients might be on it for longer. But again, it's all how we weigh those different risks and side effects. But if you have stopped tamoxifen, several months or a few years ago, I wouldn't be worried about ongoing risk to your uterus once you're no longer exposed to the medication.
It wasn't a personal question. I'm just giving you, yeah.
Yeah.
And I'm going to ask you a question. The elephant in the room for me and for over the years has been discussed, debated, ovarectomies for HR positive women. Where are we with that?
So it's a truthfully a case by case discussion because there's so many factors that go into it. Now, effectively, when I give someone an injection to induce menopause, I'm kind of medically trying to achieve the same thing as an oophorectomy. So oophorectomy, again, being surgery to remove the ovaries. Um, In hormone receptor positive breast cancers, we know that because those cancers are being driven by estrogen and progesterone, that reducing the estrogen level does prevent those cells from growing. But all of this, again, is predicated on an assumption. So we're almost like treating a worst case scenario in that if you've had surgery for breast cancer, basically one of two things is possible. Either the surgery removed all the breast cancer cells or it did not. And we might not be able to find those breast cancer cells, so we can't actually answer that question. Because if I knew right off the bat that you had no cancer cells left, then we wouldn't need to do anything, right? You wouldn't need to go through any of these medications. And so what we do is we say, well, let's assume that there are some cancer cells that were left over. We know that the cancer cells that got cut out were sensitive to estrogen and progesterone, so let's try and block those cells' ability to grow. And then basically, as we kind of do these different treatments, we're trying to estimate what is the chance that some of those cells might have been left over. And so in some of those cases where we're doing more aggressive estrogen targeting treatment, we typically talk about doing at least 5 years of estrogen blocking or ovary blocking treatments. So things like injections to block the ovaries. And a lot of times patients will ask, what happens after those 5 years? And some of that we're still trying to figure out. And each person's individual risk tolerance is different. Some patients, for example, pregnancy and fertility is really important. And if that's the case, then cutting out the ovaries probably isn't the smartest idea up front. So we have to weigh a lot of these other factors in terms of what's the risk of the cancer, what's the patient's preference. Some people don't mind injections, but don't like the idea of a surgery. Some people are like, I'd much rather just have a procedure and be done rather than having to come in for injections for 5 to 10 years. So there's a lot of factors that make it a very individual decision.
Thank you. The next question is, vaginal estrogen therapy is said to be safe and does not become systemic. Is there a chance that for some women, a small amount could become systemic? And if so, could that pose a risk for someone with HR-positive breast cancer?
Again, very, very good question. So historically, we were quite worried about this potential risk. And there was multiple studies that were done, and the vast majority of the studies suggested that the amount of systemic absorption from topically applied, so like a cream inside the vagina, are very, very low. I've actually become a bit less worried about it over the last couple of years. There was a big study in 2024 that sort of gave me more confidence in saying that this is okay. I still do remind patients to avoid what I call systemic hormone replacement, so things like tablets or patches where you are getting systemic exposure. We definitely want to avoid that. But this paper in 2024, it looked at almost 50,000 breast cancer patients in Scotland and Wales. And what they did was they followed these patients to say, they were all breast cancer patients, and they followed them to see who actually got prescriptions for vaginal estrogen, and then whether those patients had a higher risk of breast cancer recurrence or not. And what they found essentially was that there was no evidence of an increase in breast cancer specific mortality in patients who were using vaginal estrogen compared to those who did not. Now, I do have to give a caveat here that this wasn't a randomized trial, and so we don't know. There could have been potentially some biases. So, for example, if somebody has a very, very high risk breast cancer, their physician probably told them maybe you shouldn't do this. But having said that, for the vast majority of breast cancer patients in the early stage setting, I think that this is something that I'm comfortable trying, especially if non-hormonal options aren't working, because this is a pretty significant quality of life issue, but also it can lead to other medical problems like urinary tract infections that can also be quite serious. And so, I always counsel my patients to try the non-hormonal options first. Things like there's different vaginal suppositories that are non-hormone based. If those are not working, then I think talking to your medical team about the pros and cons of using vaginal estrogen is a very, very reasonable thing to do. And then I often counsel my patients that there's kind of a standard dose that we would typically use for vaginal estrogen, but there's nothing saying you have to use that same dose. And so a lot of my patients, what I tell them is when you're in the maintenance phase, just try and decrease the frequency with which you use it and see what the minimum amount you actually need is to control your symptoms. And so I have patients who, instead of typically the maintenance is like once or twice a week, I have some patients who use it like once a month. And so they're taking much less than kind of the standard dose to try and minimize that risk. But can I definitively say that there's zero systemic absorption? I probably can't tell you that. But what I can say is that the data is suggesting that there's not enough to actually meaningfully change a breast cancer outcome.
Thank you. I'm going to hand it over to Jacqueline, please.
Thanks, Kathy. I wondered if you could talk a little bit about the rise of breast cancer diagnoses in young women, how it's being reported in the media, and what you're seeing as a medical oncologist.
Yeah, so it's an interesting situation for sure. I think that breast cancer incidence, it's true that it is increasing in younger populations, especially in the 20s to 40s. But I think the part that maybe isn't getting as much media attention is that I think it's still actually, thankfully, a relatively small portion of the total population of people who are in their 20s and 40s. And I think some of the information in the media can actually be quite frightening and somewhat sensational. And the reason for that is that the media reports will often give you what we call a relative risk. So it's kind of the change in percentage. So as an example, there was a study, I think it was in 2019 or 20, that reported that, compared to the 1980s versus the 2010s, there was like a 45.5% increase in breast cancer rate in people who were in their 20s. When you actually go into that study, the actual risk went from like 3.9 cases per 100,000 people up to 5.7 cases per 100,000 people. So it's really important to remember that even in the 2010s, the likelihood of a woman in her 20s developing breast cancer was 6 per 100,000. And so it is thankfully still a very rare occurrence. But having said that, despite kind of there being a lot of ways to interpret statistics, I think we're trying to do a lot of work in terms of understanding better, like, why is this happening? What factors can we modify to try and prevent this from happening? And some of it is actually turning out to be simpler than we maybe give ourselves credit for. Like things like just being physically active and exercising more can actually reduce your cancer recurrence, including breast cancer. And so there's things that you can actually do as a person who doesn't have breast cancer to reduce your risk of developing breast cancer. And exercise is probably like front and center there. But just when you're hearing an article or reading an article, just make sure you understand whether are they telling you a relative difference or are they telling you what we call an absolute difference? So again, the absolute difference in this case was like going from 4 cases to 6 cases per 100,000, so an extra 2 people per 100,000. But when you say like, oh, how do we divide those two together? It looks like a 50% increase almost.
Can I ask a question around that before you go on? So are we understanding better that the lifestyle has changed for us as humans in terms of being less active? And do you think that the way we eat and what we consume, do you think that has any factor into,
Yeah.
younger
So
age being
yeah,
diagnosed?
I think that lifestyle does play an important role. It's hard to separate these things out. So, smoking and lung cancer is a very strong association. It took us decades to figure that out, and that's a very common activity and a very common cancer. Um, Things that, diet studies are really hard to do. Most people
Yeah.
don't remember what they ate last week, right? And if I did a randomized trial where I was like, you're randomly assigned to the group that's not allowed to eat food X, what's most likely going to happen is if you did eat food X, you're just probably not going to let me know that you did, right? And so that
Yeah.
makes these studies really, really challenging to do. And so I think getting good studies and that's part of why on the news you'll be like, oh, chocolate is good for you, chocolate is bad for you, this is good for you, and this is bad for you, is because there's lots of these correlative studies that are very kind of weak evidence, to be honest with you. What I think is more important is kind of in general having a healthy lifestyle. So exercise, we have fantastic data for. The more physically active you can be, um, the lower your likelihood of developing cancer and the higher likelihood of you being cured of your cancer once you have a cancer will be. I have a lot of patients ask me like, hey, I've been physically active. Why did I still get this cancer? And again, I kind of half joke with them that like, maybe if you weren't physically active, this would have happened 10 years ago. Right.
Mm.
And so just because you are physically active, even if you get a breast cancer diagnosis, that doesn't mean that physical activity isn't actually still working to help you. And I think that's a really, really important thing. And then truthfully, the new Canada Food Guide is actually not a bad place to start if you're looking for making dietary changes. It's a lot better than the old Canada Food Guide. But having a mix of, getting lots of like vegetables and fruit is really important, but getting a mix of carbohydrates and proteins is really important as well. And avoiding
Thank you.
your saturated and trans fats for sure.
Great, thanks. Go ahead, Jacqueline.
Thanks. So touched on this a little bit, but maybe you can just elaborate. So for those individuals with premenopausal hormone receptor positive breast cancer, the thought of ending 5 years of endocrine therapy and potentially returning to a regular cycle for X number of years before you hit the natural menopause time can feel pretty scary. I just wondered if you could talk a little bit about sort of the long-term data we do have, if there is any, in terms of returning to regular production of hormones that were feeding that breast cancer at one time.
This data is evolving over time for sure. And if I'm being entirely honest, part of the trouble is that these studies take a really long time to do. So for example, if we had a study that we wanted to start today, even if I ignore all of the ethics and legal and all that kind of stuff that we have to do to get it off the ground, we'd need a few years to recruit patients. Then we'd have to treat them for 5 to 10 years. And then we'd have to follow them for 5 to 10 years or even longer to actually know what the difference was. And so the study that we start today, we might not have actual results until 2050. And so that's a really important thing, I think, to think about. That's not to say that these studies are not happening, but it's just a lot of the studies that we're using are based off of trials that started in 2010 or 2012 right now. And so it was in 2018 that we started to use ovarian suppression more, because that's when the study actually came out saying that, you know what, suppressing the ovaries and inducing menopause was more helpful than just doing tamoxifen on its own. And so truthfully, we don't have a lot of really long-term data, aside from the fact that prior to 2018, we weren't doing ovarian suppression in the first place. I think it still comes down to an individual risk assessment. And so do I have some patients in whom we actually decide to go beyond 5 years of ovarian suppression, which is what the study that was published in 2018 looked at? Yes, we do have that. I have some patients who are really worried about the risk of recurrence. And for that type of patient, maybe doing something like a surgery to remove the ovaries, especially if they're not planning on having children, is worthwhile, because then they know that their estrogen levels are going to be suppressed going forward, even after we hit that 5-year mark. But it's certainly not something I would recommend to every single patient. So someone who has a really early stage breast cancer, we know that inducing menopause at the age of 35 has other long-term health consequences to your heart health, weight gain, bone health. And so it's not just a black and white thing where it's like, this is the only thing. We need to think about the whole person, not just the lump.
Thank you.
Thank you. I have a quick follow-up to that in terms of studies. So we know that some women are living like 30 years, 25 years and beyond with HR positive breast cancer, and others, obviously. But women that have gone into these studies and, did what they had to do in these studies in the early days, I call them the early days, wouldn't it be wise to find out if these women are still with us? And if they are, what is their quality of life? What was their lifestyle like after they received that diagnosis and never had a problem with it? Wouldn't that be a good start to get a good pool of individuals to do some assessment analysis?
Yes. And that's basically what we're trying to do. Now, again, remember that on these clinical trials, like a lot of stuff happens over time. People move, they might not be followed at the cancer center anymore. So there's a lot of challenges in collecting some of this data. People also truthfully get sick of being asked all the time. So like when we're doing like even like the progress tracker that I'm part of, we're kind of blasting every 3 months to be like, hey, please fill out this survey on how you're feeling and what you're doing. And over time, you see this attrition of like people who are like, you know what, this is too much. I don't want to do this anymore. And so it's easier said than done, I guess, is what I'm trying to say. Not that it's not important. And I think as health systems, as we get better, as health technology gets better, we're better able to collect this data. And we're also thinking about things differently now than we used to. Even the way we approach our entire health system is different than we used to think about it. We're now trying to collect health information in a way that we can actually use to enhance patient care, as opposed to just being collected as a record for somebody to look back at if something went wrong. And so that in and of itself, I think, is a huge change in a positive way.
Thank you. So it's Rebecca. So you'll take some questions from the live audience now?
Yes, thanks, Kathy. So we have a question coming in about birth control. So trying to figure out, how much of it actually affects hormone positive breast cancer, or if any. Can you speak on that
Right.
a bit?
There is a small effect of birth control in terms of increasing the risk of hormone receptor positive breast cancers. I'd have to kind of go back and get the exact numbers. So I'm kind of trying to dig back in my memory here, but there was a study that was published, I want to say about 2018 or 2019, that specifically looked at this. And essentially what it found was, depending on the type of birth control method used, and again, I don't remember the exact numbers off the top of my head, but I think it was somewhere around sort of between 5 and 10 per like 10,000 patient years, extra cases. Um, and so there is a small increase in the risk, but it's also not a massive, massive increase in the risk. And I think, again, everything we're doing is weighing individual risks and benefits. I think it comes down to, what is your family history? What is your personal history? If you've had a history of breast cancer already, then I'm less likely to want you to be taking something hormonal for birth control. Um, but everything we do in life is weighing risks and benefits, right? Every time we walk across the street, we've decided that the risk of being hit by a car is worth crossing the street to get whatever it is you're doing on the other side. And it's a similar thing where uh, there's pros and cons to each side of this, and you really have to weigh those out. And cancer is obviously a scary big thing that we think about, but at the same time, like, sometimes taking small risks might still make sense.
Yeah, that makes sense. Um, Another question that's not specific, I'd say, to HR positive, but perhaps you can speak to it anyways. Does lymph vascular invasion indicate a higher risk of metastases?
So yes, if lymphovascular invasion is present, what that basically means, I kind of use analogies to explain this, but imagine, like, again, I'm in Calgary, so I'm going to use Calgary as an example, but let's say the city of Calgary was your breast cancer. So just like the city of Calgary is not just one thing, it's actually like 1.5 million people. The breast cancer within the breast is actually made up of lots of different little cells. And so your lymph nodes would be kind of like surrounding towns and cities. So near Calgary, we have a town called Banff and Lake Louise. And so those would kind of be like your lymph nodes, and the highway connecting Calgary to Banff and Lake Louise would be kind of like your lymph vessels. Um, Lymphovascular invasion, when they talk about that on your pathology report, is basically saying, like, that same highway that would connect the breast to the lymph nodes, Highway 1 or the Trans-Canada Highway, within the city of Calgary is called 16th Avenue. And what we're actually asking is, were there cancer cells within the breast tumor itself? So within the city of Calgary, were there cells that were basically on 16th Avenue and therefore easily able to drive to the lymph nodes or drive to Banff or Lake Louise? Um, and so if you do have lymphovascular invasion, that does slightly increase the risk of the cancer. Again, that's one of many factors that we're actually incorporating. And so I mentioned the Oncotype DX test earlier, which is one of the tests that we can do. There's other genomic tests that we can do on cancers to better understand their risk that we use in specific cases. And we actually have found that even patients who have deposits of cancer within the lymph nodes, they might actually be lower risk than we previously thought. And so we historically used to offer chemotherapy to anybody who had lymph nodes involved. But now we're actually finding that just having the lymphovascular invasion or having the lymph node involvement, your cancer might actually still be lower risk. And there's certain tests we can do to potentially identify those so that we can avoid things like chemotherapy in some of these patients. So again, does it indicate a higher risk? Slightly. Is it the only factor? Absolutely not.
Thank you. I love analogies. That was great. Back to you, Kathy.
It was fun going to Banff and Lake Louise.
Yeah.
Exactly. Yeah.
I couldn't have picked better places, actually. Okay, so I'm going to go back to our questions that were submitted. What are the long-term side effects of medications taken to reduce the risk of recurrence?
Um, at the risk of kind of using the cop-out answer here, it depends. Because it really does depend on what type of medication you're talking about. And so I'll kind of maybe use categories of medications rather than specific medications, but starting with like chemotherapy. So there are some potential longer-term side effects that can happen depending on the specific type of chemotherapy that's used. So things like numbness and tingling in the hands and the feet, we call that peripheral neuropathy. Um, some chemotherapy medications might have effects on the heart. And so we monitor, with ultrasounds of the heart or a test called MUGAs to actually try and make sure that the chemo is not affecting the heart. Um, Rarely, like very rarely, about 1 in 1,000 chance with certain chemotherapy drugs, we can cause a second cancer, a type of blood cancer called the leukemia. Um, and so we have to weigh all of these risks and benefits really carefully when we're talking to patients about whether chemotherapy makes sense for them or not. Um, the estrogen targeting therapies can also be associated with some potential long-term side effects. We talked a little bit about the uterine side effects associated with tamoxifen. Tamoxifen can also rarely be associated with blood clots in the legs and the veins. You can also get cataracts rarely with tamoxifen, so I'm always telling my patients to make sure they're getting their eyes checked every year as well. And then the aromatase inhibitors, although they don't cause the uterine side effects or the blood clots, they can decrease your bone density and increase your risk of osteoporosis. And so there's a lot of things that we have to monitor for when we're thinking about these medications. And then there's also other types of treatments, not so much in the hormone receptor positive breast cancer setting right now, but for triple negative breast cancers, we're using more immunotherapies where we're trying to use the immune system to help fight the cancer. And that can lead to autoimmune side effects that can potentially also have long-term consequences.
Okay, great. Two questions come to mind. I volunteer at the hospital. One person asked me about cold urticaria. They get it. They apparently she's experienced going anywhere cold in the cold area after taking tamoxifen, a rash or some sort of reaction. Is that part of a symptom? Have you heard of that?
I mean, it wouldn't be something that I would expect commonly. Um,
Okay.
every single one of us is different and we metabolize medications differently, and you don't have to walk too far down the street to find like somebody who feels like a medication is the best one for them and somebody else who feels like it's the absolute worst, right? And so a lot of this is the individual, and how your body processes the medication, how your body metabolizes the medication. And part of my job as a physician is trying to work through some of that with patients to see like how do we better manage some of these side effects, um, and what can we do to try and help mitigate some of these side effects. So could it be a side effect of tamoxifen? It certainly could, but it wouldn't be something that I would expect someone else starting tamoxifen to necessarily get.
Mhm. And there was something that came up in a patient reported blindness with tamoxifen. I don't want to alarm anybody, but
You know?
that's been a
So again,
little,
cataracts are a reported side effect of tamoxifen. And that's a big part of why having the annual eye checkups is so important. And I think I always tell my patients if they're on tamoxifen that their optometrist needs to know that they're on tamoxifen. Because I have had a few notes come from optometrists where they're like, hey, FYI, I'm seeing some changes that might be related to tamoxifen. And then we actually talk about it and talk about, do we switch you off the medication to prevent this from becoming more severe? And so with any medication, if you're worried about certain side effects or you're noticing certain symptoms, the most important thing to do is to actually talk to somebody about it.
okay, great. And I guess my next question, how are the side effects from these medications best managed? I guess,
Yeah. I think step one is prevention.
yeah.
And across the board, whether it's chemo, whether it's estrogen targeting treatments, whether it's immunotherapy, whether it's surgery or radiation, um, the more active you can be, I've kind of harped on this already a little bit, but I find people who are more physically active get fewer side effects from treatment. I used to think it was the other way around. I used to think that it was just because they weren't having as many side effects, they were able to be more active. But the longer I do this, the more convinced I am that the people who are physically active get fewer side effects. So that's the first and most important thing. And you can start doing that before you start any treatment. And it doesn't have to be like, you don't have to run a marathon. But if you're doing just enough to get your heart rate elevated a little bit, so, if you're walking late for an appointment and you're kind of going a bit faster and you can just feel your heart pumping, that's enough intensity of exercise as a starting point. But wherever you are, if you can add a little bit more, the guidelines typically recommend 2.5 hours a week of moderate intensity or better exercise, which would be that heart rate going up a little bit. But if you're doing none, doing 30 minutes is better than none. If you can kind of do 10 minutes 3 times a week, and start from there. That's something that I think is really important from a prevention point of view. We work really hard as a medical team to also try and give you suggestions and things that you can do to prevent side effects. So sometimes we give you, for example, if you're on chemotherapy, I'll usually give you like a cocktail of medications to prevent nausea from happening so that you're not throwing up. Um, for the numbness and tingling, the peripheral neuropathy, sometimes like keeping your hands and feet cold during the treatment, as long as you don't get frostbite, might actually help reduce some of the chemotherapy circulating to the fingers and the toes. With certain chemotherapy medications, there is some data that maybe doing cold capping might help reduce hair loss. It doesn't work for all patients and it doesn't work for all chemotherapy regimens, but there are some things like that that we can do to try and prevent some of these side effects. And then we do treatments to actually help mitigate the side effects if they do happen. And again, knowing what those side effects are and talking with your care team is so important for that.
Thank you. Great. Jacqueline.
Thank you. I wondered if you could talk a little bit about recent research developments in the sort of endocrine therapy space. I know there's some new things being discussed that aren't standard of care yet, but maybe you could just fill us in.
Yeah, there's a lot of different things happening in this space. There's, as I mentioned, a medication called ribociclib just got Health Canada approval within the last 10 days to be used in conjunction with estrogen targeting therapy for certain breast cancers. So one of the categories that we're working on is these CDK4/6 inhibitors. And as I mentioned, they block one of the escape routes that cancers can use to get around the estrogen pathway. And so they've been used now in the stage 4 metastatic breast cancer setting for about 10, 12 years. But they're moving into the early breast cancer space. There's also a type of drug called a selective estrogen receptor degrader, or SERD. And those medications also can get around some of the ways that cancers might be able to overcome some of our estrogen targeting treatments. So the aromatase inhibitors and the injections to induce menopause, the ovarian suppression, they both just try and reduce the estrogen level. But one of the things a cancer can do is mutate the actual receptor, something we call an ESR1 mutation, where the receptor kind of turns itself on whether or not estrogen is there. And so our medications that just take away estrogen are no longer effective because the receptor's on anyway. And so these SERDs can potentially be helpful because they actually try and degrade the receptor. And so they might be able to work in this setting. And there was actually a study that was just presented at the beginning of this month at the American Society of Clinical Oncology that suggested that potentially testing for this ESR1 mutation and then switching to something like a SERD may be helpful. Although again, those drugs do not yet have FDA approval in the US or Health Canada approval for this indication yet in Canada. But that's, I think, where things might be moving towards in the future is, can we do additional testing to actually better understand whether a cancer has developed any resistance to certain treatments so that we can inform what treatments we give going forward.
And is that ESR1 mutation something we can test for?
So there are tests available. I always caution people in that, right now we don't fully understand the test characteristics yet, which is how to interpret the test exactly. And also I would caution people against, especially when we don't actually have all the final results from these studies. There have been things where we see these presentations, we get really excited, and then you actually get a bit more follow-up data, and it's like, oh, actually, this didn't work the way we thought it would. And so I think we still need a bit more data before I'd be comfortable routinely recommending it to patients. In theory, yes, you could privately pay for testing, but I'll be honest in that as your oncologist, I don't entirely know what I would do with that result right now. And so I'm a bit worried that it would increase anxiety over a result without me actually being able to do something about it yet. And I really want to be able to, when I'm doing a test, know what I'm going to do as a result of the test so that I can actually help change the trajectory of a disease. And so right now, I don't know that I'd recommend doing it.
Thank you. Speaking of anxiety, I wondered if you could just talk a little bit about how you support your patients to manage fear around risk of reoccurrence.
It's a really good question. And I don't know that there's like one right answer to this. I think the first thing is that it's human and normal to have that happen. I think that's the first thing, is like trying to remind patients that, like, this is normal. When you go through a major life event, Kind of say like if somebody goes off to war and comes back, we don't expect them to be exactly the same person they were when they left. And it's a similar thing when you're going through a major life event. You're kind of coming back to a new normal, if I can call it that, as opposed to like the old normal, which is sometimes really hard for people around you to understand. Um, and even me as an oncologist, like I don't know if I fully understand it. Like I can only kind of relate to what people tell me, as opposed to having lived it myself. So I think that's the first thing though, is understanding that like this is normal. Um, the second thing is, again, talk to your care team about this because there are resources that we can use to help. And so we have across the country, there's psychosocial oncology programs, there's patient support organizations like Wellspring, uh, like CBCN, like Breast Cancer Canada, that can actually help with connecting you with resources and support. Um, Breast cancer is complicated and there's a lot of information, and it can be overwhelming, and having these different kind of resources to help you out through this journey is really, really important. But it's also really important, I think, to kind of compartmentalize them in some way, shape, or form, especially while you're going through cancer treatments, um, because it can be, again, really, really overwhelming. So some patients of mine have like said that there's like a specific day of the week that they're willing to give updates, and everybody else can like wait until next week. Or there's certain people in your social circle who are like the people you talk to about your cancer, and maybe there's other people who's like, your job is to talk to me about anything other than cancer, just so that I can feel like a human. So there's different strategies you can use in that regard. The last thing I'll kind of mention on that note is it's also very, very common that while you're going through kind of the more intense, I'll call it, period of treatment at the beginning, like especially with things like chemotherapy, surgery, radiation, where it's just like, things are happening like every week or every day sometimes. Um, when that finishes and then suddenly you're being seen less often at the cancer center, treatments are happening a little bit less frequently, or now you're just on oral treatments, even though those treatments are equally as important as the chemotherapy, they feel less intense. Um, that's the time at which a lot of times I find like the anxiety and fear can kind of like creep up on you. And it's a weird time because everybody else around you is like, great, you're done. Everything should be good now. And so just be really aware that that is a time when there's that transition, where it's, again, normal to feel more fear or anxiety. And again, we have resources as a health system to try and help with this.
I would say yes, that is very true. Once that umbilical cord is cut, that is when the anxiety, at the beginning, they feel, oh, great, it's done. But it's a bittersweet feeling because then you feel like you're on your own now, and you have your own, and we do use the term new normal. And one thing that I would like to add is that patients' anxiety is really high over the wait time for a test and the wait time to get the results of a test. A simple mammogram is fine, but to wait after you've had a diagnosis of a breast cancer and you're going for your follow-up, and to wait for that result for a week or two or whatever, that is such an anxiety-provoking thing for patients. And I wish that there could be something that could be done, like an on the spot, relaying of the results, because
Yeah.
that is very, very fear-inducing for patients.
No, it's a really good point, and I think it's a complicated question too, because sometimes you actually need a little bit of extra time to make sure. Um, I'll give you an anecdote here, but I remember I was covering for an oncologist, and there was a patient who had called in, who wanted a chest X-ray result like immediately. And when we looked at the report, I was like, this report just doesn't make sense. And so I kind of like talked to the radiologist. It turns out they'd made a typo, and the typo was really simple. It was just like they were supposed to say that something was not present, but the not didn't get transcribed. And so all of a sudden it looked like there was like a recurrence of this cancer. And if we hadn't taken the time to actually go back and look at things and get the radiologist to confirm, the report that we would have been giving the patient would have actually been quite a bit worse than what it turned out to be, which was like, oh, it actually looks totally fine. And so all that to say that sometimes a little bit of like that time, there is important stuff happening. Um, Nowadays, people are getting reports in a lot of systems in Canada. You can get the reports through, your online access to your chart. And that's a bit of a double-edged sword too sometimes. So I have some patients who really like knowing kind of what the report shows and kind of going through it so that when they come to see me, they can ask questions about the report specifically. I have not an insignificant number of patients who have actually told me that like I intentionally choose not to look at the report anymore because it just freaks me out and I don't understand it and I'd rather you tell me. And so part of this is also figuring out what you're comfortable with as a patient. And again, talking to your physician about it in terms of like, how are they trying to manage the results? What's their process?
Good. Okay, so I'm going to give it to Rebecca. You have more live questions?
Yes, I do. Just to follow up on that last point, Dr. Khan. I think that you're right about that my chart being sort of a double-edged sword where patients maybe they almost sometimes need a disclaimer to say, don't
Right.
necessarily if you don't want to know your answers straight from, your website, make sure to just, wait until we have a
Right.
discussion about it. I was at the Canadian Breast Cancer Symposium last week, and there was a patient who spoke exactly about that, how she was diagnosed with metastatic disease by looking at her my chart
Right.
on like a Friday evening. And so then she was sitting with that anxiety all weekend, which is and longer than that. And that's not necessarily how we want people to find out about such a
Totally.
complex and difficult diagnosis, right?
Yeah, absolutely. And sometimes the jargon we use is confusing too. Like pathologists, if they see a breast cancer cell in a lymph node, the pathology report will often say that this is breast cancer that's metastatic to the lymph node. And they take the word metastatic very literally, which means the
Yes.
cell moved. And that doesn't mean that it's stage 4 breast cancer. But again, if you're reading that report, I can totally see how,
Mm-hmm.
because the rest of us who are not pathologists interpret the word metastatic very differently.
Yes,
So
yes.
just really, really important things to think about.
Absolutely. And I will take this moment just to plug some of our upcoming webinars that we're hoping to have, we're looking to have in the later part of this year. We are going to be doing one on recurrence, and we are going to be doing one on BRCA and hereditary family history. So just watch out for those to come through your inbox if you're interested in signing up for those ones in later in the year. So going back to some of the patient questions. So how much do hormones, how much hormones are produced by ovaries after menopause?
Really, the ovaries would not be producing estrogen after you've gone through menopause. The issue is that the rest of the body still produces small amounts of estrogen. And the way they do that is through this enzyme called aromatase. And so you've heard me talk about a type of medication called an aromatase inhibitor. And what those do is they actually block these non-ovarian sources of estrogen in the body. And that can come from breast tissue, that can come from fat tissue, the adrenal glands. So there's different organs within the body that produce these small amounts of estrogen. When you're premenopausal, the amount of estrogen that your ovaries produce like dwarfs the rest of the body. Um, and so that's why our approach to premenopausal versus postmenopausal patients is quite different. We can't use aromatase inhibitors by themselves in a premenopausal patient because the ovaries are making more estrogen anyway. And so
Mhm.
they just detect that the rest of the body has stopped and then compensate for it. But that's why we have to combine them with injections to suppress the ovaries.
Thank you. Um, why is the score of Oncotype DX cutoff based on age and not menopausal status?
Truthfully, I think the main reason for that was because it's really hard to define if someone's in menopause or not. And I think in just the nature of that study, it was easier to kind of use the age as kind of a surrogate. They were still trying to get at menopausal status. Um, I think if I could go back in time, I would like it to have been stratified a little bit better by actual menopausal status.
Mhm.
But it is complicated trying to figure out whether somebody is like, for example, let's say you've had obviously if you had a hysterectomy, you've had your uterus removed. Well, we can't tell if your ovaries are still in. Are you menopausal or not? Because you can't have periods because the uterus has been removed. Even if you've had like a polyp or a fibroid in the uterus and you've had an ablation procedure, you might not have periods anymore, or somebody might have had, they're getting periods every 6 to 8 months or something, and they're in that perimenopausal period. So there's a lot of nuances to like when is somebody actually in menopause, and unfortunately, our blood tests don't necessarily answer that question definitively either. And so I think that's part of why that happened with that study. Although I
Okay.
wasn't actually on the committee for that study, so you'd probably have to ask them to be sure, but that's my guess.
Thank you. And one last question before I kick it back to you, Kathy. Is there an alternative to tamoxifen if you've had a history of blood clots?
Yes, so that's where the aromatase inhibitors would be the alternative. If you're premenopausal, that means we have to combine it with the injections to suppress the ovaries. But yes.
Okay, thank you.
Okay, I'm going to go to the submitted questions. Can you explain what hormone resistance means in HR positive breast cancer? How do you know when a cancer has stopped responding to endocrine therapy? And what does that mean for treatment option? I think we kind of touched on it a bit.
Yeah, there's kind of two definitions of hormone resistance that I think of. So one is what I call primary endocrine or primary hormone resistance, and that's basically like we've started. Let's say you've had like surgery for breast cancer to remove it. We start an estrogen targeting treatment, and the cancer still comes back within the first 2 years. That implies to me that the cancer has completely got around our estrogen blocking treatments very, very quickly, and that's why we call it primary, meaning it was probably estrogen resistant from the beginning. Um, the other is what we call secondary estrogen or hormone resistance, which is where it develops over time. So you've been on estrogen targeting treatment for several years, at least 2 years, or you finish your estrogen targeting treatment and then the cancer comes back, but it comes back within 2 years of stopping, and that's what we call secondary endocrine resistance. In the early stage breast cancer setting, after a tumor has been removed, it's very hard for us to actually know that that's happening, because again, we can't see the individual cells. Going back to that analogy I was using of Calgary and Banff, all of our tests right now are kind of like being in a plane at 30,000 feet looking down at the ground. You don't see the individual people walking around. You see the towns and cities that we've built, right? And so similarly, none of our tests that we have right now in 2025 can actually get down to that individual cellular level, to actually answer the question of are there breast cancer cells left or not. And if there's no breast cancer cells left, as I mentioned earlier, then hormone resistance is not an issue. Right? But if there are breast cancer cells left, then that's when the hormone resistance becomes an issue. Over time, things like the ESR1 mutation that I was talking about, as we start to understand how a breast cancer might become resistant to our estrogen targeting treatment, then we can potentially start to design tests, things like circulating tumor DNA, where we can maybe do a blood test to see, do we see a presence of something that is expressing this ESR1 mutation, and maybe that helps us change our treatment, because that might be a sign that there is some estrogen resistance developing.
I have my next question addresses asks about ESR1 and PIK3CA, and those mutations develop over time. Can they develop over time?
Yes.
They can.
So they definitely can. So some cancers have them already. But you have to remember, like every cancer that happens, whether it's breast cancer or some other part of the body, this started out as a normal cell in the breast, for example, and something changed to cause that cell to start focusing on itself and become more selfish and focus on its own growth. And those are different mutations. I kind of think of mutations as like spelling mistakes in a book. And if you're like rewriting a book by hand, like I'm not going to speak for everybody here, but I would make a lot of spelling mistakes. But I don't necessarily know where exactly the spelling mistake is going to happen before I start copying that book. And in our DNA, every time a cell divides, it has to make a new copy of the DNA. And in that process, the body naturally makes spelling mistakes, and those are mutations. And that's the reason that people have different eye color and hair color and skin color and so on, is these different mutations. A lot of these mutations, just like a lot of spelling mistakes, they don't actually change your ability to read that paragraph or sentence, and the meaning of the sentence is not changed at all. However, if you get the wrong spelling mistake in the wrong place at the wrong time, maybe the meaning of that entire sentence or paragraph changes. And that's a mutation that can then potentially lead to a cancer developing. Over time, cancers become like worse and worse spellers. And so they acquire these other mutations and more spelling mistakes as they keep dividing and growing. And that's how something like an ESR1 mutation or a PIK3CA mutation might arise over time, is just because more of these spelling mistakes are happening. And the difference becomes that when I'm giving, for example, an estrogen targeting treatment, um, all of the cells that are sensitive to that treatment, they're going to be blocked by it. But if there was a cell that had developed this mutation, then because it knows how to get around the treatment, it can keep growing. And so that's why these mutations might develop over time. And it's also why a lot of our research is focused on how can we identify these mutations and then be proactive about trying to stop them. So as an example, those CDK4/6 inhibitors I was talking about, the reason we're adding them in for higher risk breast cancers is to try and cover the possibility of some of these resistant mutations.
Great, thank you. Jacqueline.
Sorry, I was muted there. I wondered if you could just talk briefly about tests like Signatera. I know you said that it's very difficult to get that really specific view of whether breast cancer cells are still in the body, but can you maybe just speak to when tests like Signatera are helpful?
Yeah, I think the tests like that are going to become very helpful in the future. Again, it's really understanding how do we use them. So like I said, this study that was published or like presented at the conference just last month is starting to help us understand how we might be able to use these tests better. It's a bit of a kind of the Wild West right now where there are certain companies that are just like offering these tests because they know that people will pay for them. And then there's other companies and institutions that are actually trying to do the studies to use them properly. And I think over time, what you're going to find is that although people can make kind of a quick buck by selling it now, it's the ones that are studied properly that are going to be the ones that we all end up using in the future. And so what I would really kind of suggest to people right now is talk to your oncologist and see, like, are there clinical trials that are looking at some of these types of technologies that you might be eligible for? Because there's different trials happening kind of across different centers. And to me, that would be the best way to use a test like Signatera right now, is if it's being done in the context of a clinical trial so that all of us can understand how to use the results of that test in the future.
Thank you. And one last question from me. In this great age we're in of gross misinformation and the do your own research movement, I just wondered, how do you recommend that new breast cancer patients navigate online misinformation and unregulated wellness industry and all of those things we're coming up against?
Yeah, that's a big challenge for sure, because breast cancer affects so many people. Like, everybody knows somebody who's been affected by breast cancer. And when you're dealing with breast cancer, and I'm sure Jacqueline or Kathy, you can speak to this as well, it's like the number of people who have advice for you is astronomical. Um, I think the biggest thing is to start by understanding, like, what are reliable resources. Where do you start from? And a lot of that is things like the Canadian Cancer Society, things like CBCN, things like Breast Cancer Canada, where they are actually trying to provide patients with information that's a bit more validated. Speaking with your healthcare team, again, is a great place to start. I think it's really important to do your own research and kind of find things, but also really, really important to understand that, like, there's different qualities of evidence. And so a lot of what I've talked to you about today is based on things like randomized control trials, where basically we took a large group of patients, and then the only difference between the two groups was whether they got treatment A or treatment B. And then if treatment A was better, we know that treatment A was better because the treatment is better, as opposed to a study where we put all of the low risk patients in one group and then the high risk patients in one group and then said, oh yeah, it was the treatment that made them better. The reality there was actually we had biased the study from the beginning. And so there's a lot of literature and evidence out there. But being critical and asking people questions about, like, how do you back up what you're saying is so, so important. And how many patients have actually gone into, like, the data that you're talking about. And so a lot of the studies I was talking to you about is like 70,000 patients or 50,000 patients that they've looked at to say that, vaginal estrogen might be safe, versus something that's out there that's like, this is person X and look at how good they did, where it's like one person. Because maybe there's something about that one person's specific cancer that made them sensitive to that specific thing. And it doesn't mean that that's going to apply to everybody. And so understanding the quality of the evidence is really, really important. And again, this is where your healthcare team can try and help you understand some of this.
And with that, I'd like to add my own little comment on this. I come from a time where there was no information. You had to seek for the information, and your information came from the hospital, came from your multidisciplinary team that worked with your cancer center. And now, as time goes on, has gone on, there is so much information, and I find that we need to get into the middle, because it doesn't have to be the way it used to be, but it also has to be tailored a little bit so that we come to the middle with too much and not enough.
And that's part of our
Yeah.
job now. And I think part of
Okay.
my job changing as an oncologist is like part of it is actually trying to answer some of these other questions too.
Yeah. Yeah.
And I'll
Anyway,
actually use that opportunity just to plug our patient path tool, which kind of is able to, filter out what your treatment might look like based on your type and your subtype, and your stage. And it also does a really good job of, allowing you to kind of take what information you want at when you need it and not just throw everything at you all at once. So taking a more of a slow approach to accessing that information in a way that's meaningful at the time of whatever stage you are in that journey.
and with
Absolutely.
that, I'm gonna have Dr. Khan, I'm gonna give him the last word. And I ask everybody this: what is one thing that you could give as an overall message to the audience after having all this discussion? What is one thing that you could, offer as a comment or
I
encourage?
think I'm going to cheat and give two things. Number one is you're not alone when you're going through this. So both from the health system side and like your healthcare team side, and also from your own like social network and groups like CBCN, you don't feel like you're alone going through this, and feel free to ask questions because people are here to help you. I think that would be the first thing. And then the second thing I've kind of harped on a couple of times already, but like anything you can do to increase your physical activity will help.
Great points. And with this, I want to thank you, Dr. Khan. Thank you, Jacqueline, for this great and very great engaging discussion. And with this, yeah, I apologize for any questions that were not being answered, because there's only so much time we have, and I'm happy that we were able to address some of the questions that came in. And they were all excellent questions, and thank you for joining us today. After this session, you will be sent a survey to provide feedback on this session. Your responses help us make these sessions better. So please give us your feedback. And once again, I would like to thank you to our sponsors, Pfizer, Bayer, Tercera, AstraZeneca, and Eli Lilly. And thank you again, everyone. Thank you, Rebecca, for putting this together. Have a great day. Have a good weekend, everyone.
Thank you, everyone.
Thank you very much for having me.